So good morning. We'll start off the next session. I'm Chandru Sundaram, and we have three talks in this session. The first one is Rooma SInha, Impact of Immersive Experience of Training Surgeons with 3D Immersive Vision Using Virtual Reality. Rooma.
Good morning, everybody. Thank you, Vattikuti Foundation, for inviting me here to share this experience and also to be with me all through these 14 years that I have been doing robotic surgery. I wouldn't be standing in front of you if Vattikuti Foundation was not with us. Thank you so much. So we've been talking about training in the last few sessions, and I understood that training today is definitely off the operating room. So I want to talk about the impact of an immersive experience in using virtual reality when we want these surgeons in learning to watch the surgery, but this time from inside the console. I bring you greetings from a city called Hyderabad in India. It's a fast-moving city with a lot of technological development, and that's what we're experiencing in our surgery as well. These are two pictures. The one on the right is from the banks of River Ganges in the 6th century BC. An Indian surgeon called Sushruta taught surgery, and others observed. And the other, we all know the picture very well, is from Massachusetts. But see one, do one, teach one worked well when we did open surgery. As we moved to laparoscopy, we needed different skill sets. We needed to view 3D in 2D flat screen. We operated on straight instruments, single pivotal point, and of course, we needed hand-eye coordination. But the game changer was when we introduced robotic surgery, because other than the domain knowledge of doing surgery, we also needed technical knowledge. We identified a gap, and this gap in the training, that first of all, most surgeons who were moving on to robotics did not have long periods of leave to be able to come for long fellowships. Second, the traditional 2D teaching on flat screens did not give them the exposure of a stereoscopic 3D vision. The console training became much difficult because watching on 2D, when you sit down on console with a 3D stereoscopic vision, is an entirely different ballgame. So to get accustomed to this vision, we thought we had needed to do something. So we devised a solution called Immersive Gynecological Console Series, where we recorded surgery and then had the surgeons coming in to re-experience in virtual reality. They looked at these videos by using the VR meta headsets and their ability to pause, rewind, re-enter critical steps, and experience the depth of the human body. How it works? It works in 3 steps. Number 1, we capture our video in 3D stereoscopic vision with a dual-channel video recorder from robotic console directly. Then these are then converted into VR-compatible immersive format and then aligned with meta headsets. And number 3 is then surgeons come in, wear the meta headsets and immersive playback to see how they can actually view these surgeries.
And as a next step, we have converted that into a VR convertible form, and it is all presented in virtual reality. They can wear the VR headset and they can experience it. The recordings are all done in 3D, which is one of its kind. And we have converted that particular 3D recording into virtual reality supported format. An application is built, precisely a VR application. Trainee will sit in a simulated environment. So that's how they'll get an immersive experience of how the surgery looks like. This is a complete collaborative experience where multiple trainees wearing multiple VR headsets will join the same session. So we have gamified the version so that it is so engaging, and whatever the trainer is looking at, the same thing is being looked by the trainees. It will be very easy for the trainer to teach what she is trying to explain. This is all within the intranet, so that you do not need any internet or anything. Even in a remote place, you can just have an empty router, you can sit, and all the people can get connected to that particular network and they can get trained. We have built such a solution which is very flexible and scalable, and you can deploy it anywhere.
So using this idea, we devised a 3-day master course for young gynecological surgeons who are wanting to learn robotics. And the course highlights and objectives were live surgeries, didactic surgical case discussions using the VR headset, learning how to manage complications, both surgical and technical, and of course handling the ureter, which is one of the most difficult parts, especially in stage 4 endometriosis, and hands-on experience on docking and VR simulation courses. So these didactic surgical discussions actually had 5 segments. hysterectomy, myomectomy, endometriosis excision, reconstructive surgeries, and some ancillary procedures. The key advantages of this console series was that the surgeons could understand the depth, it became teachable, they could participate in decision making, would stop at any time and discuss how did we make that decision, repetition without fatigue, and of course bridging the console gap. Trainees observed live cases in operating room, had hands-on experience on draping and docking practice, and the most importantly, at 8 hours didactic session with simple and complex cases of hysterectomy, myomectomy, endometriosis excision surgery, and reconstructive surgeries, a total of 20 modules which they watched on a 3D virtual reality MetaQuest 3 head-mounted sets for immersive learning. The faculty interacted during this and could stop and discuss the surgical step at any time during the video on a virtual reality platform. The trainees watched the surgical steps with a 3D stereoscopic view, just like an operating on the console. After a month of the course, the trainees were asked to fill a feedback form anonymously on an email survey. The questions on this feedback form were designed to ask if the course fulfilled their learning objective and the component of the course that they benefited most from. We asked if the 3D virtual reality surgical experience improved their learning and if it helped them in a subsequent surgery, which could be open, laparoscopic, or robotic. If the answer was yes, then they were asked to type the procedure. If the answer was yes, they were then asked which type of procedure or which particular step that they became more confident after the course. The study questionnaire also asked if watching a live surgery in future with a 3D virtual reality meta headset be more useful than a recorded surgery. The results were actually very, very eye-opening. The surgeons who participated in the study, most of them had more than 10 years of practice, and almost 100% were already doing minimal access surgery. Close to 50% actually said that their objectives were fulfilled, and there were no score less than 6 in this classification. Did the 3D VR experience improve their learning compared to 2D? Most of them, 50% said yes, and again, no score was less than 6. Did the course help in subsequent surgery? Almost 97% said, and you can see the graph that they have voted that they found help in hysterectomy, myomectomy, endometriosis excision, in the posterior dissection of adherent rectum and endometriosis, as well as ureteric dissection. Watching live surgery while a surgery was going on in the OR with meta headset, almost 80% said that they may like this, but we were not sure. And of course, would you recommend this course to others? Almost 100% agreed that they would use this course to benefit their surgical training. So the highlights of this VR console series became to step inside the surgery not just as an observer, but an experienced it in 3D. We could pause, rewind, zoom, tag a step, critical anatomy highlights could be done. An immersive series could actually become a voice-guided surgery which they could watch maybe once or twice. They could understand the decision-making insights at every step, and because it was recorded, there was no problem while stopping a step and giving them the insights. What am I thinking now is what the proctor would actually ask, and the candidates would answer and would actually have a deliberation as to what and why we did that. So the proctor connect became a very important step of this. So how did the user journey? It's to discover, enter, experience, reflect, and apply. So I'll just...
I think I have gained a little bit of confidence.
You can see these surgeries absolutely in the VR module as you see it in the robotic console. Can improve the surgical expertise.
It gave us a good immersive knowledge of what was going on, and definitely there are no distractions when you're using the VR meta headset.
This recently which I did robotically, lots of tips how to approach huge uterus with multiple fibroids. How during that surgery, the previous course that I had gone for to Hyderabad helped me doing my latest robotic surgery.
So moving from this experience, we actually realized that it shortens the robotic learning curve, enhances surgical precision and safety, democratizes expert learning globally. As you can see for this course, already we are having candidates from Southeast Asia coming in, and bridges the gap between the knowledge, skill, and the judgment. The future, we would like this AI-based performance analytics here so that we can understand what the candidate is actually learning, personalize their care in the learning pathways, and of course become a more global immersive program as we go. From India, I actually represent two major associations. I'm the founder and president of the Indian Society of Gynecological Robotic Surgeon. We have started this, and we want at the moment to start moving into Asia, because of my role as the president for the Asian Society of Gynerobotic Surgeons. So this has been a fantastic journey of trying something new, and we have got great response from the surgeons who have actually been trained on this module, and I hope to carry this forward in other parts of the country and world. Thank you so much.
Great. I'm Thanos Vatsoris, full professor of urology from Athens. I would kindly ask the next speaker regarding yes, the AI-guided era of low-pressure robotic prostatectomy, Dr. Vasdev from UK. Please, the floor is yours.
Thank you very much. Good morning, ladies and gentlemen. Just wait for my slides to come up. So it's a great pleasure to be back for yet again another successful Vattikuti Foundation meeting, and I've been associated with the foundation for over a decade. Obviously, very, very grateful to Dr. Bhandari for the invitation, but as I was being promoted to professor and chair, Professor Menon was one of my referees, so I'm very grateful. But my sort of conversation about this trial, which I've led in the UK, actually started about 2 years ago when I met Professor Menon. I just mentioned this concept of AI and low-pressure surgery. And those words which resonate were, it's not about the technology, it's not about robotics, it's about the patient. And I think that's what's really driven this particular trial. And I hope to showcase to you some pretty advanced data and breakthrough data which my fellows have got ready today. As we move on into the era of AI, it's becoming more and more obvious that AI is going to really help us develop as robotic surgeons, as different specialists in medicine. And being the section editor for the upcoming Gray's Anatomy, we have really highlighted quite a lot of AI use to understand anatomy a bit better. But as time moves on, what we've seen is there's a lot of AI being used, especially in the context of preoperative planning, so your MRI, your CT scan. We saw some great demonstrations yesterday. But there's very little happening in the context of what's happening intraoperatively. Obviously, a lot of robotic manufacturers are pushing for automation with certain key steps to happen, such as suturing. But I think the elephant in the room, which is the pneumoperitoneum, is still to be addressed. So no matter what robotic system you use, no matter which cavity you're operating in, what you require is a pneumoperitoneum. So this is the space which you need to generate. And since 1924, where the world's first laparoscopic pneumoperitoneum surgery was performed, we still continue to use carbon dioxide as pretty much the standard gas, because it's cheap, it's inert, it's easily available. But I do a lot of research with low-pressure surgery, so we wanted to sort of explore this a little bit more. So what's been proven so far in urology with low-pressure surgery is that it benefits patients. It's thought to be associated potentially, especially with immediate pain scores being lower on different publications. But there's a lack of consistent data with what happens post-operatively and certainly intraoperatively with low pressure, especially when you look at pain. Because pain is quite a big problem. You know, you operate on patient A in the morning who has similar pathology. You do the same operation, they go home in 2 hours. You do the same operation in the afternoon on the next patient, and they go home in 2 days. So why is there so much variability despite of you doing the same operation with the same equipment, the same robot, same anesthetist, etc.? So we set to evaluate how we can throw into the mix with AI in the context of the pneumoperitoneum. So we managed to get Oxford B approval in the UK with the Health Research Authority, and this was hosted at my center. So this is pretty much a breakthrough trial, which is the world's first trial looking at insufflation with artificial intelligence in patients undergoing surgery. We compared 2 insufflators. So we used the air-sealed insufflator, which is essentially made by ConMed, and this is a specialist valveless trocar insufflator. And we also compared this to the Strycode PneumoClear. And this is the sort of insufflator which forms the basics of the DV5 system. And these are the 2 commonest insufflators used in the UK at the moment. Obviously, we have different insufflator systems from Karl Storz and Lexion, etc. But we compared what was going on. And the onus was that we wanted to compare a pressure of 8, which is thought to be physiologically low pressure, because intra-abdominal hypertension, as described by the Society of Intensive Care, is when the pneumoperitoneum pressure is more than 12. So we dropped it down to 8. So this is a prospective, randomized, open-label human clinical trial. It was me as a surgeon. I'd done 1,800 prostates before I got onto this trial. And the anesthetists were blinded from the AI data being collected. It was a one-to-one randomization, and all the patients who came for the trial came across to have neurosafe robotic prostatectomy. So my center in the UK, we do a lot of neurosafe surgery, so we have young patients where the prostate is removed intraoperatively and sent across for frozen section analysis. We collected a lot of data points to power up our trial, but we wanted to look at 40 patients initially, basically with a pain claim. So we looked at preoperative data, and patients who were on painkillers were excluded. Patients who had a different few criteria with chronic pain were excluded, and nobody should have had any opioid or morphine within 6 months of the trial being started off. We looked at a lot of intraoperative data, of course, as you do with any data study, and postoperatively, we focused really on quality of life and pains in patients postoperatively. The reason why we got AI into the mix was using this particular device. This is a MediSense device, which is quite advanced. It's similar to an oximeter. You plug it onto the patient's finger, and it records live data as the patient's being operated using a very complex algorithm involving skin temperature, galvanic skin flow, sweat pore activation, and it gives you a number when you're operating. So with the FDA, if a number of more than 25 is sustained for a minute, it's considered to be significant nociception. And on the left is the difference between pain and nociception. So pain is what a patient perceives, but nociception, by definition, is the physiological response to insult to the patient's body. So it's more objective to capture. What we found in our patients was, obviously, the preoperative data was quite nicely matched, including age, the preoperative hemoglobin, creatinine. 7 patients in the air seal arm had had previous hernia surgeries, and 6 had had hernia surgery in the striker arm. And there was quite statistical comparison between the pathology, the prostate size, and the percentage of cause being positive. Our data so far has showed a bit of a difference between the two insufflators. So the first thing, which was very obvious when you're operating at a low pressure, is that there's a bit more blood loss with one insufflator compared to the other. We don't know why, whether this is down to a bit more venous oozing at low pressure, which is fairly interesting to see. So there was a statistical significant difference between blood loss in these patients undergoing surgery, because blood loss is a big thing with robotic surgery. We also found that it was slightly quicker to operate with the air sealed insufflator compared to Stryker, both on the console time and also on the total time. But you can see at the bottom, with the fentanyl, morphine dose, etc., because the anesthetists were blinded to the pain scores of the AI being generated, there was no real difference that they also felt and saw intraoperatively. In 1 in 20 patients with air seal, we had to up the pressure, really down to hemostasis and visualization. And 5 in 20 with Stryker, we had to up the pressure again because of visualization and hemostasis. Now, the nociceptive AI data is very complex to evaluate, so this has taken a couple of meetings to get it right. But again, patients felt a bit more nociception when they were undergoing surgery at low pressure with Stryker compared to air seal. So this is very interesting to see how patients behave differently when different insufflators are being used. We also have looked at pain scores postoperatively, so this is still being collected. We're looking at visual analog scores. It's a little bit noisy right now, but we hope to sort of get more delineation on some themes coming up. But what we found was, especially in those 6 patients out of 40 in whom we had to increase the pressure, the amount of opioid use was higher postoperatively. So this is really resonating with the low pressure and high pressure, increasing the pneumoperitoneum pressure with higher pain use. We also looked at adverse events, so again, slightly higher, not statistically significant with Stryker compared to air seal, with ileus and UTI rates, and some patients did come back with Stryker to the emergency department for a review. So what we're picking up in this unique trial, which is the world's first looking at pneumoperitoneum and AI, is it's feasible to do. So we are going to power up our study a little bit more, and we've just started recruiting another 60 after getting ethics approval. There are differences in the two insufflators, certainly with blood loss, with procedure times, and nociception. But when we go multi-center in due course, we'll be able to validate this a bit more. And this is something which we're working on in my lab, is a feedback AI system to see if a patient has more nociception being felt intraoperatively, can the pressure automatically drop down during key steps of the procedure. So this is pretty exciting data in the future. And I just want to acknowledge my research fellows who are both associate PIs on the trial. And this doesn't happen overnight. This is a big team effort with a lot of people involved, and also Professor Prokar Dasgupta and Carol Takastika, who are key collaborators of mine in robotic research from Belgium and the UK. So I'll stop with that. Thank you.
Thank you. Next we have Dr. Raison from King's College London on mind over scalpel, embedding mental and non-technical competencies in surgical education.
Sorry, thank you very much, and it's a great honor to give this presentation. and to be invited here. And just from a personal level, from the Vattikuti Foundation, who actually supported me during my PhD as a Vattikuti Fellow, when a lot of the concepts and the work I'm going to be talking about really started my journey along this started. So I'm incredibly grateful for that. And then also for what I think is actually a fantastic title that they've given me. So what I'm going to be talking about is two concepts which I think are incredibly important in ensuring that we maintain and optimize our performance in the operating room, that of non-technical skills, and then secondly, the concept of motor or mental imagery training. First of all, in terms of non-technical skills training, this is something that we're becoming increasingly aware of, and we've heard lots of really fantastic lectures about how we optimize our technical performance, but sadly, as we know, when we're thinking about poor outcomes of our patients, in the vast, vast majority of cases, this really doesn't matter. What really matters is not our technical skill, but how we manage our patients in the non-technical aspect, so how we make our decisions, how we communicate those decisions in the operating room, the system errors that occur. And so as you can see, and what came about after this quite seminal work to Error is Human in the late 1990s, which was this report about why mistakes happen in hospital, and we know it's that these other factors. Thinking about intraoperative complications, over 40% of those are purely down to communication breakdown. So when we're thinking about how we best can serve our patients, what we really need to be focusing on is making sure that we're making the correct decisions, using the information correctly in the operating room, rather than focusing too much on technical skill, which I think is something has been occurring in the past. This is certainly obviously nothing new. This is now well recognized concepts. The NOT system, which has been developed for training surgeons in non-technical skills by Steve Ewell and his team of Return to Scotland, now is well recognized. And really these are the key domains that we need to be thinking about when thinking about our non-technical skills. And really principally when we're thinking about how we can optimize our performance, what we need to be thinking about is first of all our situational awareness, so that's how we use the information in the operating room, how we gather that information, we process that information, and how we start thinking about future states. And then on the basis of that, how we can make those decisions appropriately and then communicate those decisions and enact them. And that is the way that we can optimize our performance and more importantly, maintain safety for our patients. And of course, in an unusual basis, this happens almost automatically in many cases, and this is something that we don't need to think about too carefully. But in those cases when we start to move off our usual track, when our standard operating list doesn't really go to plan, when the case itself is not going to plan, then we find that those frameworks that we build up about how we develop our situational awareness and decision making then start to fall apart, and there we then see that in fact then our performance starts to suffer, and there we have our greater risks of errors with our patients. And so when we're talking about non-technical skills training, we need to, what we're really thinking about is making sure that we have some kind of process to maintain our frameworks for creating appropriate decisions and maintaining performance in the operating room. And some of the reasons why we start to struggle is across a number of different areas. Obviously, in terms of technical surgery, there's the concept of fatigue, which is quite important to recognize. But then also we need to think about these other factors that are occurring in the operating room in terms of our memory. Excuse me, a critical part of that is thinking about our short-term memory capacity. We know that normally we can hold approximately 7 pieces of information in our mind at any one time. However, when we have some stress, that drops quite drastically to over half to 3 to 4 pieces of information. And so when we have a stressful situation, we suddenly starting to struggle to actually be able to accommodate all of that information in our mind and use that effectively. We then have the further impact of stress, of fatigue, and then as a result, as you can see, then we start to notice that the decision making, which normally happens, as I say, autonomously and quite effectively, really starts to struggle. And that is the point at then when we start to see that errors and mistakes start to creep in, and we start building that risk of having poor and adverse outcomes to our patients. In terms of robotic surgery specifically, as we've heard already this morning from Professor Hubert's fantastic talk, there's some concepts within robotic surgery itself which make this even more difficult. Obviously, we have the console in the corner of the room, or now even in a completely different room or a completely different country. We have the concepts within robotic surgery that we're losing some of the touch and other skills that we've grown used to in terms of surgical training. We have problems with fatigue, and then also maintaining that communication with our team themselves. And so robotic surgery itself poses some quite specific risks in about how we maintain and and optimize our performance. And as part of this, what we worked on is actually a system specifically for robotic surgery we call the ICARS system, which provides a behavioral rating system for how we train and assess non-technical skills in surgery. So more broadly, how do we teach non-technical skills? So principally, this is about simulation. And again, we've heard about the critical importance about simulation and being able to run these scenarios where then we can go through these concepts and ensure that we can then meet them when we see them in the operating room. And also we need to think about other opportunities for training this as well, before and after our operating list, debriefing, considering where there were potential errors, potential complications, how we can learn from that, and even more importantly, in those times when critical error events do occur, again, it's critically important that we use those as learning events to ensure, and using debriefing that is very important. And so, why is it that we simply can't just read about this, because this is just a short course we can do, and so obviously we need to have the baseline knowledge, the baseline understanding of all of this, but then the application of this is critically important. The photo here is a photograph from the EAU Congress this year in London, where we had the opportunity to demonstrate some of this non-technical skills training within the exhibition hall, to try and raise the awareness of this. And really, the critical aspect of this is the practical training of this, to be able to go through these scenarios. And so as one of my roles at the moment is working with the EAU as leading the non-technical skills training program in developing workshops, and we built them now for the EAU annual congresses, but more importantly, certainly in my opinion, is that of the Europe courses. So that's the residency program, which is run through the EAU for residents across both Europe and the wider world in Prague. And each year we're able then to run some courses to start demonstrating, introducing the residents to these concepts of non-technical skills training, and alongside this we've also developed training modules. And so really the importance of this is starting to build this awareness and building this training about how we manage these situations where we're unfamiliar, how we maintain our frameworks to optimize and ensure that we continue to have good situational awareness, good decision making, and we are able to optimize our performance. The second thing moving on to is a slightly different topic, but that of then motor imagery training, which I think also is quite complementary to this. Now moving across to another field, and again, as we heard from the talks yesterday, that looking outside surgery is also critically important. And so now today, if you speak to any even semi-professional athlete, a critical part of their training is going to be cognitive training. So no athlete is simply focusing on the technical aspects of their performance. In order, so to speak, brain training and cognitive training is a vital part of any training approach. And so what we need to start thinking about doing, what we've been trying to do, is then introducing this into surgery itself. The photo here is really something that really resonated to me when I started my looking into this area, is that some fantastic studies that have shown that through the process of motor imagery training, your strength itself can be improved simply by rehearsing these activities mentally. As you can see, I've not undertaken this training myself, but it certainly is effective. In terms of mental imagery training, what are we talking about? So what we're thinking about is how we rehearse the specific technical performance and the technical steps very accurately in our mind. So this is not something that you do on your drive in to work before the operating list. This is something that needs dedication and concentration, but certainly it can be highly effective. In terms of cognitive training more widely, there's various different aspects of this that we can consider. As I say, mental rehearsal, motor imagery training is what we'll be focusing on, but there's also wider aspects of how we look at the decision-making and performance with any kind of technical task, with cognitive task analysis, and then also that of cognitive simulation, where we're thinking more about preparing ourselves for the performance of the task itself in terms of anxiety, mental preparation, thinking about the steps themselves. In terms of motor imagery training, going into a little bit more detail about exactly what we mean by that, as I say, it's the very closely rehearsed process of looking at a specific technical skill and going through that in your mind. And so really there are various ways about how we go about this process. The PETLEP Model 1 is most widely used in the literature, and really the focus of this is going through in a very detailed fashion, thinking about exactly how you perform that task, to the point, as you can see on this checklist, how the feeling of the needle, in this case a urethrocycloanastomosis training, how the needle feels as it passes through the tissue, and that is the kind of level of detail that you need to maintain. And so what we looked at in terms of our research in this area is whether we can apply this effectively to surgery. So we performed one of the first randomized controlled trials of this using 61 students and junior doctors, where we randomized them either to mental imagery training or standard training in terms of suturing training. The mental imagery training were given this focus training, went away and performed that at home, and then we assessed their performance in a simulated operating room, as you can see, using this urethral cycloanastomosis model. And what we found was that there was a significant improvement in their technical skill following the training compared to the control. There was no difference in the non-technical skills, which again follows on with what we know about how these training works. What we went on to do from this is try to look in a little bit more detail about, are we actually making a difference? Is this actually making a difference to how we process and focus on information? Or is this all just a little bit of fluff and really a not true result? And so what we did was did a further study looking at 4 intermediate surgeons, where we used functional MRI imaging to look at the connectivity between different networks within the brain, and to see whether this training does actually make a difference to how our networks connect together. And so we performed functional imaging before and after mental imagery training. As you can see from these graphs, there was a significant improvement, a significant increase in the connectivity between your frontal, or between their frontal and prefrontal cortices. So these are the areas related to motor training. And that was a significant result. The rest of the brain, there was no change there. So on the basis of this, we were able to show that in fact this training was having that effect that we were hoping to have, and we were improving the connectivity in the brains, and this is leading to the improvements in technical performance. So thank you very much for the time. As I say, I find that these two areas are incredibly important for training, and these are really things that we need to be considering, including more regularly in our training programs. Many thanks.
Thank you. It appears we have nothing in the chat, but are there any questions from the audience?
This is, according to me, the most significant part of the surgical training. This is how I feel it and the outcomes. Can you tell me with any data or your own data, how many training centers in the world go beyond simulation models and their efficiency-based protocol, focusing on mental makeup, managing short-term memory, managing cognitive load of the surgeons and trainees?
Thank you very much for the question. I'm afraid I don't know exactly how many centers there are across the world. Thankfully, this is something that is increasing, but also sadly we know that overall this is lacking. So through the EAU, we ran a survey a few years ago now from 500 residents and urologists across Europe about their knowledge of non-technical skills. And in that, there was a vast, vast minority, sadly, had any kind of formal training. 15% of those had any training. And of that, it was still extremely limited. And so we know that still this is a minority. There are some countries that are doing well. In the UK, we have relatively widespread training. In the Netherlands, they also have excellent training, but then in other areas, this is really lacking. And so the program that we've set up in the AU, really what we're trying to do at a very basic level is just improve the awareness of this. And it is now at the point where a large proportion of surgeons, sadly, don't even have an awareness that this is a thing that they're thinking about. And so one of our aims, and it sounds almost laughable, is that we're simply trying to introduce the concept of non-technical skills to surgeons at an early stage so they can start to incorporate this in their training.
To your knowledge, has there been any measurement of the load, the stressors on the surgeon that is measured intraoperatively, like eye tracking or EEG or skin conductivity or heart rate, anything of that nature, on a wide basis that can impact outcomes on patients?
There certainly have been some studies, as you say. They use eye tracking, they use skin conductivity, they've also even measured cortisol, so there's quite clear demonstration that there is significant stress. That second very important aspect, though, that you mentioned about then how that relates to outcomes, we don't have that yet, as far as I know.
Thank you.
Allow me to ask the first speaker regarding your model. Has it been implicated in other specialities, and what are the obstacles that you face?
Thank you so much for your question. Right now, we have just developed it for gynecology in my hospital. We are planning to expand it because this took some time. I personally actually have developed this and invested in this. We do plan to take it forward with multiple specialties. One challenge is that if we make it available across countries, the receiving surgeon should have a 3D meta head quiz, which is an expensive piece of equipment. So I'm still working on how we could, circumvent that and make it kind of democratize it and make it available. But yes, the idea is to have multi-specialty. Thank you.
So clearly those headsets are expensive.
Yes.
So would it not be economical to have an audience like this with glasses and 3D doing exactly the same thing and have a much wider impact?
Okay, that is one thing that has been tried and happens very often in live surgeries as well. But the impact is not the same, sir. You have to wear that headset and see that it feels as if you're sitting on the console and operating, which is an immersive console. So that experience is entirely different experience than you would actually sit in a hall like this and watch on a 3D class.
That's an interesting concept because, some of the robotic systems, as you know, are not immersive. Right?
I understand, yes.
So the Hugo, for instance,
yes,
it's just as good as sitting in a hall with the glasses.
True. But then even if you look at the robotic systems, and that's my personal experience and view as well, the view is very different between an immersive and a non-immersive robotic platform. So I think that difference will remain. Thank you.
Any questions from the audience? Yeah, the question is immersive versus non-immersive truly different for patient outcomes?
Thank you. This is a question for Nick. Your nociceptor machine, what pain will it, because there are multifactorial reasons for pain after robotic surgery, how will it differentiate between various pain and how will you point it that this is due to low pressure insufflation?
So this is quite a complex issue. This is the first time we've explored this, Professor Nathan. I think, you see, nociception is the body's physiological response. So my question to this particular manufacturer from Israel when they were talking about the AI algorithm was, I said, why don't we put this onto the patients in the PACU to tell us what sort of pain thresholds it's having? The issue is because it's such a sensitive piece of kit, any artifact or movement will cause a spike. So the FDA also resonates with your question to say, is this really genuinely the case with different pressures? So before we embarked on our trial, we have done validation work which will be published on different pressures with nociception. And the key concept was, look, all of us can operate at a pressure of 15. Is that the best thing for the patients? You and I have had this discussion numerous times, even at Eris, that it's not. Low pressure has shown a degree of benefit. But in the concept of why a patient behaves differently, why is it that when you operate on one patient, you do the same operation in the afternoon, they behave differently? I think we are just sort of scratching the surface with nociception and AI, because if we can use this data to potentially drop our pressure down even more and ensure that patient doesn't have too much nociception, because when we really drop the pressures down to 5 to 6, my default is 6 when I operate, I can pretty much tell you they don't really feel much. So right now, this is going to be a multi-center trial in due course. We're going to power it up even more, looking at pain. But I think, ultimately this research will really benefit a lot of patients and really individualize intraoperative patient environment compared to other studies which are really looking at preoperative imaging, etc. So we're just trying to understand the pneumoperitoneum and AI a bit more.
So following our discussion, I went and did a trial only with used carbon dioxide and non-circulated carbon dioxide. Between the two machines we are using, but we use the lexicon, which does not reuse the carbon dioxide. It was amazing. 0 shoulder tip pain after using the lexicon, while nearly 50% of patients had shoulder tip pain with the circulated carbon dioxide.
And just another point, if I may please, Professor Nathan. You see, the FDA in the US is really supporting a lot of innovative research which reduces the dependency of patients post-operatively on long-term painkillers, because this is an international issue taking place. And I didn't even know that 20% of patients who are chronic pain users have had medical intervention done. So we are sort of reducing the intraoperative nociception, reducing pain intraoperatively, getting people home quicker. But certainly right now we're looking at 6-month quality of life. We're doing a lot of quality of life questionnaires in our trial, which we'll be publishing in due course. But thank you.
Finally, to Nick, what happened to your fantastic equipment you did in your PhD thesis, where you were measuring surgeons' stress levels in the console, looking at their muscle tension, etc.? Did it come out to become a usable machine or not?
No, well, we didn't go any further. So we were able to show that there were different stress levels with that, but then sadly after that, then it stopped.
Question for Mr. Vasdev. Regarding your insufflation, is the insufflation in some way related to the ventilation, to the visibility, to intraoperative measures that you can control?
Yes, Dr. Chandra, we can, because by default, when you operate at a higher pressure, you probably will have a better view, especially when you use insufflators, which adopt constant smoke evacuation, etc. But in the context of low pressure in our trial, we've had to up the pressure for hemostasis, but in 2 patients, certainly we found that when there was a degree of excessive diathermy potentially being used, so to clear that field out in one of the insufflators, we had to match it. But I think we have to really work now on matching a lot of different data points, because it's very complex. Doing a surgical RCT is very difficult with intraoperative parameters, but yes, visualization is a key.
But your system does take into account visualization, ventilation.
Yep. Correct, it does. So the trial has looked at visualization. We don't have a negative pressure theater, of course, but we have synthetic imaging running right now in the trial itself to see that, especially with the assistant screen, if we can wipe out the noise. So yes, we're looking at that. And
have you noticed any improvement in bowel function, return of bowel function,
so we had 2 patients who had ileus with one of the insufflators come back. The question is there more instability of the pneumoperitoneum, which is taking place? So we're doing an animal lab on that. Yeah.
Any other questions from the audience?
I have a question, again for...
Dr. Rani.
Thank you. So again, it's for Nikhil. You're obviously concentrating on the prostate, and the data you've shown is for prostates. But isn't there a bigger picture here? Everybody who does laparoscopy, whether it is robotics or whether it is conventional laparoscopy, is going to affect what they do. So wouldn't it make more sense to have arms in your study where you have other specialties? Because arguably, if you're doing a pneumoperitoneum, if you're a general surgeon doing a pneumoperitoneum, you're exposing more of the bowel to higher pressures. And if one of your endpoints is less ileus, quicker recovery, it would probably make sense to have that sort of data right from the get-go, rather than going back to it later. Thank you.
So I agree, Professor Rani. I think, we're just scratching the surface, like I said. And the problem is, right now, we have the advent of a lot of new robotic systems taking place. So everybody's developing new kit, but no one's addressing the pneumoperitoneum, which you require in every specialty that performs minimally invasive surgery. So our plan is right now to go multi-center next with Mount Sinai, with Ghent, with King's. We'll be going into a 500-patient study. And then we'll be sort of looking at partial cystectomy intracorporeal reconstruction in the next phase, followed by general surgery and gynecology will be next. Because at the end of the day, this is a high-impact study which will be present in all specialties. So exciting stuff ahead. Thank you.
Thank you very much to the speakers. We are run out of time, and thank you very much for a wonderful session and amazing meeting put together by Dr. Bhandari and his teams. Thank you all.
Time for break.